Good morning, Peter Goertz. I'm a psychiatrist. How much neurology or internal medicine is involved in the daily practice of psychiatry? Specifically, I'm going to talk about my practice. The short answer is not too much, and probably some people are concerned, oh, if I'm a psychiatrist, am I going to have to really know a lot of details about internal medicine, neurology, and keep up with all the facts? So overall, the quick answer is not a whole lot. In my practice, probably I deal with somewhat more than average amounts of neurology and internal medicine. So here's my situation. I do consults on ER patients, hospitalized patients, and I do them almost always virtually. And I also have a clinic, so patients come to me in the clinic or they have their visits virtually. Maybe about 60% come in person at this point, 70%. In the clinic, some basic medical things to focus on are blood pressure, heart rate, weight, and you want to feel free to examine patients. Not that long ago, I saw a patient who ended up having an arrhythmia. So you do sometimes pick up things. If there's any suspicion, if they have any complaints, feel free to examine them. And just to back up, some people may think, oh, psychiatrists should not be touching patients. Some people maybe have that view. I don't think it's a good thing not to touch patients. You do want to feel free to examine them. And also, in my opinion, it has other aspects. It shows the patient that you look at them as a whole person, as the psychological part, and you look at the psychological part, the physical part. And also, you are not concerned about touching them because some patients may feel, quote, untouchable. So in my opinion, it has advantages and is appropriate. So you want to also auscultate. I tend to do that routinely on patients on stimulants like Adderall. I auscultate their heart and at the same time I check their pulse. For people on antipsychotics, I check for extrapyramidal symptoms, so check for stiffness, Parkinsonian tremor, which would be about 3 to 6 hertz. And you also want to check their tongue at rest, though. You don't want to have them stick out your tongue to check for Parkinsonian tremor. Someone on lithium, you want to check for a fine action tremor. As far as lab work, if someone's on clozapine, you're obliged to check the CBC regularly, depending on how long they've been on clozapine. It could be once a week, could be once a month. And on lithium, you want to check the BMP, you want to check TSH, you want to check the lithium level. That's after 12 hours, after the last dose of lithium, you want to check the level. So those are routine things you want to check on lithium. So to check for kidney function, thyroid function, and you want to check the lithium level. And if someone's on Depakote or valproic acid, you want to check the CBC, platelets, LFTs, maybe even a serum ammonia level, somewhat regularly. And on second generation antipsychotics, you want to check somewhat regularly a fasting lipid panel, a CMP with fasting glucose, blood glucose, and a hemoglobin A1C. If someone's on a stimulant, you want to check a CMP and an EKG periodically. And sometimes you do pick up things. There was one patient who I just routinely did an EKG on. He was on a stimulant, and he had a quite pronounced arrhythmia, so it was fortunate that we checked the EKG. So that's the clinic. On the consult service, which I do generally virtually, so I cannot examine the patients physically on the consult service. You want to also check weight, check the blood pressure, heart rate. You want to check for medication allergies. And you want to And that's something that can blindside you, because at the end of the consult, you may recommend a medication and then realize, oh my God, I didn't even check for allergies. And that can bite you potentially. So you want to have your own routine and go through medication allergies. You want to check the medication list, including PRN medications, as needed medications. And that medication list for, let's say, a hospitalized patient with multiple medical problems, that medication list can be quite long. And you want to be careful to really look at that medication list, including the PRN medications, so you don't end up prescribing drugs, or not prescribing, but recommending as a consultant drugs, that psychotropic drugs that may interact with their medical medications. So for example, if someone's on an anticoagulant, Depakote may not be the best medication to recommend for that patient, because Depakote can cause thrombocytopenia and even platelet dysfunction. You want to look at what IV fluids and what IV medications the patients are getting, let's say on a hospital ward or in the ER. You want to check the EKG, so check the reading of the EKG. You want to check possibly previous EKGs, compare the two. And if someone has a prolonged QTC interval on the EKG, you may want to avoid, if possible, antipsychotics, because generally they can prolong the QTC interval, which can lead to dangerous arrhythmias. You want to, if they've had one done, you want to check the echocardiogram, see what the ejection fraction is. You want to check a chest x-ray, look at the results of their head CT if they've had one, look at the results of their brain MRI if they've had one. You want to look at lab work, blood work, and again, things can blindside you if you don't remind yourself. Let's say the people in the ER may have forgotten to get a pregnancy test. You want to kind of have a routine, so you think of, oh, does this patient have a pregnancy test done? So otherwise that can bite you potentially if you prescribe something or recommend something. You want to check, again, the lab work targeted for what you're looking at. Let's say if you're looking at potentially starting lithium, you want to be sure there's no kidney problem, if at all possible. And if someone has low platelets, you probably, depending on how low the platelets are, you probably want to avoid Depakote. Thank you.